When I have a patient that's I'm following for castrate-resistant prostate cancer, but they're not yet metastatic, it's variable at how often we'll image those patients. And part of that depends on what their PSA level is. Part of that depends on their PSA doubling time. For patients with really long PSA doubling times, say 10 months or longer, that's a group of patients I'm pretty comfortable imaging them once a year or even less if their PSA is down, in the low single digits. But as that PSA gets up into the 5 to 10 range, I'm going to start imaging them every time there's a doubling. So if it's 10 months, it's maybe every 10 months. If it's 3 months, it's every 3 months. 6 months, every 6 months. So that doubling becomes sort of a marker for me on how to image. What I use for imaging may vary. Right now, it's still traditional CT and bone scan, but I think we're open to understanding where the optimal time is for using some more of our molecular imaging, both in terms of being understand the prognosis and implications, where to look for metastatic disease to show up by CT and bone scan in the future, but then also to be able to prepare what they might be available for in terms of molecularly targeted therapies as well. Once patients become metastatic, castrate-resistant, then I'm typically imaging patients every 3 months that they're on a treatment. And the reason for that is because PSA alone may not tell us the whole story of these patients. And there are patients that had disease progression on both the PREVAIL and Cougar 302 study that didn't have PSA progression, but had new radiographic disease. You're only going to find that if you continue to monitor and check for that. So yes, there are cases where we'll cut this back after maybe a year or two, but at least for that first year or so, I like to image every 3 months on a therapy. So when I think of a drug like Radium-223, I typically like to image at 3 months. Now that wasn't done in Alsimca, and you don't have to do it, but I want to look to make sure I'm not missing some disease biology. I stress the tumor in the bone so much that now we're going to see biologic disease growing elsewhere. Has this disease changed? Is there a new biology afoot that radium's not tackling that is progressing elsewhere now that I've maybe stopped or we've seen progression on their prior hormonal therapy? Are there other complications that these patients are developing that I'm not aware of, like fractures? To pick those kinds of things up, we're going to need to do imaging, and we want to know about that because it can impact on how we support as well as manage these patients. In some patients, I'll stop radium therapy and switch if they've got new visceral disease. And it'd be good to know that. But that's a relatively rare complication. The majority of my patients, even if they show signs of new or progressive disease on bone, are not necessarily progressing. That can be a flare effect, and I'll follow that and complete their radium course.